Hello, hello, my friends. Oh, here, hold on. Hello, everybody. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, October 19th of 2025. Time for another live IC support group meeting. What happened last weekend? I couldn't do it last weekend. I actually don't remember why. Yeah, anyway, wasn't able to be here last weekend. So sorry about that. But life gets in the way, my friends. Life gets in the way. Sometimes we feel good. Sometimes we don't feel good. Sometimes technology is funky. Sometimes it's okay. It's the great adventure. And if there's one thing I've learned as I've gotten older, it's that change is inevitable. We got to roll with the punches and be flexible and adaptable. As Tanya Tucker said, about the tree that will not bend in the wind. Yeah. We want to be anchored, but we also want to be able to adapt over time. So here, hold on one sec. Let's see here. It's been a very, very busy week here at the IT Network. I have been working my tush off on new projects for you guys. Let me see if I can get this started. We'll see. We'll see if this cooperates. I have been out all morning, so I'm just kind of putting things together right now. No, I don't want to do that. No, I don't want to do that. I want to do that. I want to do that. Okay. Excellent. Excellent, excellent, excellent. So it is fall. It is a time where we are all, I don't know what your weather is like, but ours has gotten cold. I am now cold all the time. I need one of those shirts saying, yes, I am cold. So our furnaces are on. We've had a lot of rain here in California. Hello, Kelly. Hello, Carrie, you guys. Right now, I'm streaming on 3 platforms. When I'm looking here, I'm looking at YouTube and Facebook. When I'm looking down here, I am looking at Instagram. Hello there. Hello there. So my purpose in doing these meetings is to help newly diagnosed patients who might be struggling with interstitial cystitis. Hello, Johanna from Columbus, Ohio. It is cold there too. I am in Santa Rosa, California. And it's down in the low 40s at night now. I'm shivering at night, which is because I'm a California girl. That cold weather, I don't know how you guys handle the cold. I do not like the cold. Anyway, my goal here is to help newly diagnosed patients who might be struggling. We want to work with any grizzled veterans out there who are struggling with flares. You're not really sure how to treat those flares. I'm happy to take any questions from family members or friends. When I do these meetings, we've had anywhere from, because we're on 3 platforms, so we might have anywhere from 25 to 150 people watching it at one time. Every day's an adventure. But inevitably, it's going to be watched by almost 1,000 more patients. So this is an opportunity for me to share news. This is an opportunity for me to just kind of reach out to those patients who are struggling at home. I know for those of you who are listening from home and you might be watching this video after I do this meeting, you are not alone. This is not your fault. I don't want you carrying any shame or blame about your condition. You are hurt. Just like somebody who's been hit by a car, you are hurt. Our goal now is to try to understand what that injury is and try to heal that injury. But it's complex because in pelvic pain, it's not just your bladder. Yes, you've got bladder symptoms. You're up all night peeing. I understand that. That does not mean that your symptoms are being caused by your bladder. It means for many of us, that your bladder is being victimized by something else in your pelvis, because nothing operates in isolation in the pelvic cavity. Everything influences everything. You got to think about it. In a woman, you got the bladder right next to the uterus. So if you've got a fibroid tumor pushing on your bladder, you're going to feel it. If you've got endometriosis attached to your bladder, you're going to feel it. For men out there, if you've got tight pelvic floor muscles, and for women, if you've got tight pelvic floor muscles, those muscles are squeezing blood vessels, you're squeezing nerves, and then that becomes a problem. If you've got pain when you sit down that gets better when you stand up, that is a pudendal neuralgia. That means we have a muscle that's squeezing a nerve. And again, yes, you're peeing all the time. You think absolutely it's got to be infection. But for most of us, it is not infection. The bladder only knows one language: frequency, urgency, pressure, pain. A bullet wound would feel like an infection. A stab wound would feel like an infection. Cancer feels like an infection. Everything feels like an infection because your bladder only has two nerves to tell you there's a problem: a nerve that controls frequency, urgency, and a nerve that controls pain. So getting a proper diagnostic workup is not just about getting a urine culture. It's about understanding the totality of what might be happening in your pelvis. It's about understanding your history. It's about understanding if you've had any injuries, if you've had any surgeries down there, if you've had a child. Was that labor and delivery difficult? Did you suffer an injury down there? Did you? I was working with a patient last week who had classic scenario. Classic scenario. Symptoms start in her 20s. We got frequency, urgency, pain, diagnosed with IC, diagnosed with a lot of other things, massive amount of antibiotics. Nothing ever worked. She's now in her 40s or 50s. I think she was in her 50s. She's had IC symptoms for decades. No therapies have worked for no bladder installations have worked. No oral medications have worked. They look at her bladder. She's got a perfectly normal bladder wall. There's nothing physically wrong with her bladder that anybody can see. And then a doctor says, I think you might want to go see a physical therapist. And she's like, why? I'm peeing all the time. And she blew it off. She just blew it off. Then she comes to me and she's like, okay, Jill, I don't know what to do next. Can you please help me? Because I coach patients every day, almost every day. And I'm like, okay, let's try to understand your anatomy a little bit more. You've had a cysto, right? Yes. What'd they find? Nothing. Okay. You've had all the lab tests, everything else. They found nothing, right? Yes. And then we get into the interesting questions, the questions that we use to try to differentiate between bladder wall versus pelvic floor. So when you go to the bathroom, can you pee on command, or do you hesitate 5, 10, 15, 20 seconds before you can relax enough to release urine? She goes, oh, yeah, that's me. Okay. And what is your symptom? What is your biggest symptom? Burning. Where is your burning? In my vagina. I'm like, okay. So it's not your bladder that's burning, it's your vagina that's burning, right? And she's like, yes. And then I introduced the pelvic floor. And it's like, what happens is if you got muscles that are really, really tight, they're working really, really hard. And as a muscle that's working hard builds up lactic acid burns. So some of the symptoms we look for in pelvic floor work are going to be burning. We're going to look at hesitation, being unable to start urination, pain with intimacy, pain when you sit down that gets better when you stand up. She checked every single box. Like, okay, we're seeing more and more signs. These are pelvic floor driven. That is not a bladder symptom. Pain when you sit down that gets better when you stand up is not a bladder symptom. And she's like, but no, I'm telling you right now, that is not a bladder symptom. Okay, have you ever had sciatica? She goes, yes. Okay, we know you have a messed up pelvic floor muscles. Sciatica is caused by tight pelvic floor muscles, specifically the piriformis. She's like, oh, okay, I kind of get it now. I get it now. And I was like, okay, so let's go back in time. When did your symptoms start? Her symptoms started around the age of 18, long time ago. So, what do you think triggered your symptoms? And she said, now, some of you, if you've watched me, you're going to be able to figure out what she said. Oh, hey, you know what? My camera, hold on a sec. Well, okay, so this is awkward. My camera on Instagram is backwards. How do I switch this? Yeah. Hey, Instagram. Okay. Okay. So again, she's checking every single box for pelvic floor, right? And then I go, okay, what do you think triggered this? Now, y'all, if you watch me, a lot of you are going to go, tailbone, tailbone. And she shared that she had suffered a tailbone injury so bad that when she was in school, she had to bring a cushion. For a month, she couldn't sit down comfortably. Okay, so now we have our triggering event. Prior to the tailbone injury, no urinary symptoms. After the tailbone injury, her urinary symptoms slowly and steadily increased as her muscles got tighter and tighter and tighter because she never got the proper therapy for that tailbone pelvic floor injury because it happened before we were doing that kind of work. So you are an anatomical mystery to be solved, my friends. You are an anatomical mystery to be solved. And our goal is to try to figure out what the underlying cause is. We don't want to chase the symptoms. We want to find, identify, and treat the underlying issues so that you don't have the symptoms in the first place. All right. So here, hold on. We've got comments here. So thank you, Marilyn. Thank you, thank you, thank you. Hello, Deborah. Yes, it's freezing for her. Deborah said I had surgery. You've been in pain again. Yeah, I'm sorry, honey. Man, I was doing my pelvic floor work this morning and I made the mistake of doing this on my incisions, on my mastectomy incisions. Oh my God. I had to go out and do some things. The whole time I was just doing this in the car. For anybody who's new, I had breast cancer last year and I had a double mastectomy. And my incisions are a bitch. They're so bad. Linda said, what's my feeling on low-dose naltrexone being used for IC pain? What's your feeling on this? Well, let's go right to the research because I don't remember what the research is off the top of my head. So hold on a second. I can't get that for you. And I'm going to come back and take all your questions on Facebook, you guys. Just hold tight. And if I miss a question, please be a squeaky wheel. You have my permission to ask. You have my permission to jump up and down. You have my permission to yell if you're trying to get my attention and I've missed it. It's okay. So let's see what. So low dose naltrexone. Okay, we've got one study with chronic pain that I can see here. Of course, the government shutdown has pretty much disabled the National Library of Medicine, so we don't have any of the new publications up there. Low dose naltrexone provides an alternative in medical management for chronic pain disorders as a novel anti-inflammatory and immunomodulator. It can offer additional management options such as oral facial conditions, and again, other chronic pain disorders. They say we need more research. I mean, listen, my position on pain is that it's got to be treated. It's got to be treated. The last thing we want is for you to be suffering over time. Hello, Rachel Ann. And our goal here now is, again, while we're trying to find the underlying cause of that pain, if we can treat that pain compassionately and aggressively so that you're not suffering, that's exactly what we want to do. Our challenge here is we have the opiate crisis. Patients are not given Norco or Vicodin like we used to be given 30 years ago. I mean, that's what I was given, praise God, because I was in agony and it really, really helped me. So today we're trying to do non-addictive pain meds, non-addictive pain care strategies. From a supplement standpoint, really our top supplement for IC pain now is Peora or P-Leaf, palmitoyl ethanolamide. We have a 2019 study showing that 87% of IC patients who use PEA reported a significant and progressive reduction in pain over time. So that's now kind of our frontline resource because it acts to calm nerves down. And what's driving a lot of the pain in IC is we got really, really, really irritated nerves. So that's what I take. I take PEA. And it has been tremendously helpful. Now, my phenotype is interesting because I have a perfectly healthy bladder wall. There is nothing wrong with my bladder at all, despite the fact that I used to have horrific bladder pain. I am a pelvic floor patient and I am a widespread pain patient. That means I have a history of IC, but I also had a history of vulvodynia and IBS and TMJ and migraines. That happened in my 20s. We now know what that is. That is the result of it. That's a more aggressive injury that affects the central nervous system. So anybody who's struggling with nerve sensitivity, anybody who's struggling with widespread pain that's related to nerve sensitivity, PEA is going to be our very first suggestion. And we've got the research to back that up now. So in the IC Network shop, it's called Peora on Amazon. You can get it on Amazon. It's called Peora, or it's called P-Leaf, P-E-A-O-R-A, or P-E-A-L-I-E-F. So, with getting back to the low dose naltrexone, I just want to know about side effects. I think it's really, really important that whoever's considering that, listen, there's a lot of people online saying this and that, do this and do that, and they feel better on it. In the end, it's your responsibility to research the risks and the benefits and the side effects so that you are fully informed as you're starting that med. And I, for example, have a very, very sensitive heart. I get arrhythmias very, very easily. I cannot touch caffeine with a 10-foot pole. Oh my God, I miss coffee. I haven't been able to drink coffee in years. Not just because of my bladder, but because of my heart. And every medication that I look at, I look for a history of tachycardia or arrhythmias, because if it's there, I'm not touching that with a 10-foot pole. I have been in the hospital way too many times with my heart. And as the doctor says, Jill, you're not going to die from this. You're just sensitive. It's like, thank you. Great. Anne says, I have a yeast infection. I took 2 doses of diflucan, felt I got no discharge today, some burning. Do you think it's a bladder flare or still yeast? Well, honey, and she says, what's the difference between vaginal and urethral flare? Is burning and pressure considered? Okay, girl, those are a lot of different questions. So how are we going to differentiate between a candida infection and a bladder infection? Well, number one, can you have candida in your bladder? Yes, you can. And our IC research team, the former IC research team at the National Institutes of Health, were the ones who found it. And they were able to correlate fungal levels, candida levels, with bladder pain in IC patients. So why are we going to be more vulnerable to fungal infections? Because we've all taken unnecessary antibiotics. Every single one of us. If there's a patient out there who's at risk for fungal infections, it's us. Because what's the very first thing almost every doctor gives to a potential IC or pelvic injury patient? It's antibiotics, just in case. Okay, so it is absolutely possible to have a yeast infection not only in your vagina, but also inside your bladder. So the question then is, why? antibiotic use. So, Anne, have you been on antibiotics recently? Because that's going to create the foundation for that. The other thing that's going to create a foundation for chronic candida infections is eating a lot of sugar, because yeast need sugar to grow. So anybody with chronic yeast, one of the very first things you do is you back off your sugar intake. You back off your carb intake massively to stop that yeast from growing. Now, as somebody who had a drug-resistant Candida glabrata infection for 2 years from long-term antibiotic use, I will tell you that Candida in the urine, in the urinary tract, is absolutely agonizing. It's like IC times 10. The pain was off the charts. But I never had a vaginal discharge ever with my chronic Candida infection. What I had was just chronic vaginal irritation and chronic vulvar irritation. And eventually, I took a lot of diflucan like you did. If you look at the drug information sheet for diflucan, what you're going to see is, if you look at the details, there's going to be a line on the back side of the thing that says some fungal infections will not respond to 2 pills of diflucan and require long-term, more aggressive therapy. A quote like that. I was one of those. I had to do diflucan 3 times a day for an entire week. And we were doing near liver toxic levels. So they were monitoring my liver levels constantly, trying to kill the super drug resistant infection. Eventually, we were able to kill it on the inside, but it kept coming back. And it's like, why? Well, it always came back if I ate ice cream. Anything with milk sugar fed it. So I had to back off that. And I remember one day the pain was so severe, I basically kind of went to urgent care. I got an urgent appointment in my urology department. They did a sonogram. They did a sonogram because they thought I'd popped an ovarian cyst. That was negative. And then he did the pelvic, and he gasped when he looked at my vulva. He said, "Jill, I can see the yeast right now burrowed into your skin. Aren't you using the yeast cream we gave you?" And I went, "No, you gave me diflucan. Why do I need yeast cream?" And he explained that because when you take diflucan orally, not enough of it arrives in a significant therapeutic concentration at the skin where the candida sometimes lives, which is why they almost always will give you a nystatin cream or a Miselex cream. Monostat isn't nearly as effective because most yeast infections out there are very drug resistant to monostat. So you can buy that, but just know it usually doesn't work so well. Okay. Anne says, what's the difference between a vaginal and a urethral flare? Well, a urethral flare is very sharp when you pee. A vaginal flare is not. And is burning and pressure considered IC with pain? Burning and pressure is usually caused by tight pelvic floor muscles and or estrogen atrophy or a problem with the skin on the outside. Hello, Gay. Hello, Debbie. Debbie says, my bladder speaks 3 languages. Hello, Diane. Rachel Ann, thank you so much for the 200 stars. Debbie says, can you be my doctor? No, I'm sorry, I can't be, even though I got a big giant lecture from a doctor at Harvard who was like, Jill, why didn't you become a doctor? Why didn't you stay as a researcher? And I'll tell you exactly why. I did surgery for a year when I got my drug development degree. And it turned out I was actually a pretty good surgeon. What I absolutely sucked at least I thought I sucked at, was creating anesthetic dosing. There's a lot of math there. And even though I've taken calculus and stuff, it just wasn't intuitive for me at all. And in my brain, I'm like, a doctor has to have a much more intuitive grasp of creating proper dosing. And I struggled with that a bit. Anyway, this doctor from Harvard, who's a friend, was like, Jill, this is why we have tutors. It's like, oh, sorry. Oh, the Lord works in mysterious ways. It does. But luckily, I can take all that training that I've had and apply that here and at least be a good educator. That's my job, is to be an educator. Hello, Ellie. So you guys, this is a live IC support group meeting. This is for men and women with pelvic pain and or bladder pain and or prostate pain. So Rachel Ann says, a lot of people are saying they're happy with low dose naltrexone. Okay, so Rachel, here's the deal. We have distinct patient groups now. Not everybody's the same. Back when I was diagnosed 30 years ago, everybody was told that they had an incurable bladder disease. Today, we now know that that's absolutely not true. In fact, the great majority of patients have an absolutely normal bladder. And for the great majority of patients now, we now recognize that it is it's being driven by nerves and muscles rather than the bladder wall. And so, you know, we no longer tell patients they've got to be on antibiotics for a long time. We no longer tell patients they need to be on Elmeron or various bladder treatments for a long time, because we basically know that doesn't work. Today, we phenotype. We try to figure out what group you're in first, because your group is going to determine your treatment. And so the problem with online and the online groups right now is you got apples, oranges, and bananas in the same group, and you can't rely on information from other patients if they're not your phenotype. And understand, I started the very first groups online. Like, I'm the fairy godmother of the IC movement online back in 1993. And, you know, being a support group leader for 32 years, as I have been, and I have worked with millions of patients now. I mean, we were working with 250,000 patients a month through our website for many, many years. I've worked with patients in 90 countries. If there's one common thread we have seen consistently from the time I got involved, is that bladder treatments don't work for a lot of us. They just don't. They never worked for me. Never, ever. And back in 2008, in the late 2000s, when we started learning about the role of the muscles, and then we started getting pelvic floor assessments, and then I got my pelvic floor assessment, and guess what? My muscles were so hard, they were like concrete. My triggering event was falling on my tailbone when I was 13. I had my first symptoms when I was 14. So again, groups. So there are kind of 5 key groups that we look for. I use a phenotyping system developed by the doctor who ran the IC research program at Stanford University. Oh, here, hold on a sec. I got a question here. Ritani on Instagram says, I've been on Elmeron since more than a year. It is great, but I always say, what if one does and does not work anymore with neck? Well, listen, number one, Elmeron is now rarely used. And the reason why is because it's associated with patients going blind. This is big. I got 2,000 patients in my study. More than 50% of those patients who have used Elmeron now have eye damage and symptoms of eye damage. And this is why Elmeron has a very big black box warning on it. It's to warn you that there is a significant risk of permanent progressive eye damage. So it is just not the first therapy. I don't know any doctor right now who is writing big prescriptions for Elmeron anymore. The risks outweigh the benefits at this point in time. And more importantly, if you go to the IC Network website, I have an article called, here, it's right here. The Tragic and Tarnished History of Elmeron. This is our latest magazine. It's called the IC Optimist, that goes over the approval of Elmeron. And it turns out that when you actually look at the sequence of events that led to its approval, it's absolutely alarming and disgusting. That the FDA for 5 years refused to approve it. They refused to approve it. Why? Because in the data submitted to the FDA, only one doctor had success. Every other doctor who tried to use it in those formal studies had no success with it. The only doctor that had success was the guy who had the patent. And so the FDA said, hey, wait a second, we got financial bias here. We need another study without the patent holder to prove that it is safe and effective. And the company refused to do it. They refused to do the study. They said, oh, let's just recalibrate we'll recalculate the data for you. They submitted again to the FDA, got denied again for the exact same reason. Give us a study without the guy who owns it or owned the patent. Eventually, 5 years later, it was approved on compassionate use data, not another study. The FDA didn't get that study for 18 years. Elmeron was floating to the wind and for 18 years available, prescribed to tens of thousands of IC patients. When that study was finally done without the patent holder, led by Curtis Nickel, one of the top IC researchers in the world, guess what? It failed. It failed. And that research team thought that it would be pulled from the market the next week. And then, now we've got a lot of research about adverse events. We've got a lot of research about the eyes being damaged, and we have growing research now about inflammatory bowel disease. And some patients have had to have their bowels removed, their colons removed. They have colectomy. So what's hard for you is you're like going, I feel better on it. So let's take a dive into that for a moment. Elmeron is a coating. It's like a chemical Band-Aid. So Elmeron doesn't heal the bladder. Elmeron covers up any wounds or irritation on the bladder, so the bladder, whatever is going on with the bladder wall, is not being impacted by urine. So it is literally like a chemical Band-Aid. Okay, it's a coating. So the fact that a coating helps you tells us that we've got a bladder wall issue going on. And now we have to figure that issue. Number one, is it Hunner's lesions? Probably not, because Elmeron never been found to be helpful with Hunner's lesions. Is it chemocystitis? Did your symptoms begin as you went through chemotherapy, or you're drinking a lot of Mountain Dew, or Diet Coke, things like that? The bladder can be injured through chemical exposures. God forbid you're using ketamine. Ketamine is well known for causing issues. Okay, if you're not a chemocystitis patient, the next thing we're going to look at is genitourinary syndrome of menopause. So think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste, because urine is body waste. Urine contains ammonia and urea and all sorts of bad things. So how can the bladder hold ammonia for hours and hours at a time and not get damaged? How does the bladder protect itself? Well, the way it protects itself is with a really thick coating of mucus. So your bladder is like your mouth. It's a hollow organ that's wet and slippery on the inside. And that mucus plays a really important role in how your bladder defends itself from urine. Okay? Unfortunately, mucus production is estrogen dependent. So when you're young and have a lot of estrogen, you got a lot of mucus. But if you're on birth control, if you've had a hysterectomy, if you're on Lupron, if you're on estrogen suppression meds, or if you're just getting a wee bit older like me, guess what? You don't have the estrogen anymore, which means you don't have the mucus anymore, which means your bladder's more vulnerable, which means, something that coats your bladder is kind of helpful. Kind of helpful. So most patients got off of Elmeron years ago. I mean, people started transitioning off of Elmeron 10 years ago, number one, because it just got so expensive, they couldn't afford it. And then 4 years ago, 5 years ago, when the eye research came out, that was a nail in its coffin, so to speak. So what did they switch to? They switched to a chondroitin-based supplement like Bladder Builder, Bladder Rest, Cystoprotect, or Cystomend. So there you go. There's 4 supplements that offer a similar coating effect without the issue, without the risk of the adverse events and things like that. So, number one, you need a proper phenotyping. We need to figure out if you are a GSM patient. If you are, then therapeutically we're going to approach it very differently. There's going to be some topical estrogen to help your skin make its own mucus, combined with a different coating, which is going to be Bladder Builder or Bladder Rest, one of those, as your swap. Now you're going, okay, now wait a second. This is just this crazy lady on the internet telling me this. In 2006 at the San Diego IC conference, Dr. Lowell Parsons, a man who owns a patent for Elmeron, who happened to be my first speaker when I did my first IC conference, was asked, will I have to take Elmeron for the rest of my life? And he said, no, you just have to figure out if it's helping you. How do you do that? You reduce the dose. So if you're taking 4 a day, you go to 3. See if your symptoms change. If they don't, go to 2. See if your symptoms change. If they don't, go to 1. Now, at the same conference, Dr. Theo Harides, another big IC researcher, who's the guy who invented Cystoprotect, was also on the stage, and somebody said, I can't afford Elmeron. I'd like to switch to something more affordable. Can I switch over to something like Cystoprotect? And the answer was, yeah, sure. That's an option you could try. You won't know until you try it. Okay, what's the right protocol for that? And they said a 1-to-1 swap. So if you're taking 4 Elmeron a day, what they said is, okay, 3 Elmeron and 1 Cystoprotect. Do that for a week. See if your symptoms change. If they don't, do 2 and 2. See if your symptoms change. If they don't, go to 1 and 3. I know that there are a very small number of patients who have tried to get off of Elmeron, and they just say it hurts too much. And for those patients, then you got to get your eyes checked every year aggressively, because we know that the eye damage can progress even after you're stopping the medication. I mean, we've got research showing 7 years after you stop the med, the eye damage can continue. Karen says, Bladder Builder, cool. Is it like aloe vera? We don't recommend aloe vera anymore. And we haven't for a couple of years now. And that's specifically because of phenotyping, right? And so the benefit of aloe is that it's soothing. You can put it on a sunburn. You put it on a sunburn, it soothes the sunburn. It's water soluble, it washes off. And so if you have an irritated bladder, yes, you can use a little bit of aloe to soothe that bladder. But aloe in the end is not going to repair the bladder, because the bladder is not made of plant material. There is not a single published study in any medical journal that shows that aloe is helpful for IC and or the bladder. And you know what? Let me just do it again. Here, hold on. Oh, except the National Library of Medicine hasn't been updated. But let me just see. I'm going to search for interstitial cystitis aloe. So you should have everything up to 3 weeks ago. Nothing. Aloe was popular 20 years ago. Here, let's do. Nothing. I got nothing here. Okay. So The reason aloe was popular 30 years ago and 25 years ago is because it's the only thing we had. I mean, it was the first supplement. The company was created by two sisters, one of whom had IC. She said it helped her. They had some very good marketing savvy. They started this company. They ended up getting into a fight with each other, so they ended up creating two companies with the same formula. And they were very savvy. They sponsored every IC event, so they got a lot of name recognition. And I sold aloe for decades in the IC network shop because, again, it's all we had. We had aloe first, then we had Cystro Protect. When Cystro Protect came out, patients did so much better on a chondroitin-based supplement rather than an aloe supplement. And so that was like 20 years ago. So most of those patients that we've worked with, they only save the aloe for flares. It's not a daily long-term thing anymore. As validated by phenotyping. Because again, if your phenotype is pelvic floor, you got to put your money into physical therapy. Please don't buy a lot of supplements. Supplements are not going to fix tight pelvic floor muscles. And understand the people who make aloe are probably going to be mad at me saying that. I'm giving you my opinion based upon the research. You can go to the National Library of Medicine. You can search for aloe interstitial cystitis. Nothing. You search for aloe and chondroitin. You search for interstitial cystitis and chondroitin. You're going to find studies. You search for interstitial cystitis and PEA. You're going to find a study. You search for IC and lactoferrin. You're going to find a fantastic study. So we don't want you to, what's the right word here? Money is tight for everybody. Everybody, myself included. Money is tight right now. And so if you only have a little bit of money to spend on your IC, let's do it on something where we've got a study that shows it can actually work. Okay, so Kelly says here, to get off Elmeron, I should try to switch to Bladder Builder. Yeah, you could just do a one-on-one swap and give it a try. Elmeron does not cause drug resistance or anything at all like that, so you don't have to worry about withdrawal symptoms. It's not a medication that does that. But most patients that I've worked with, just once they heard about the eye issues, they just stopped it immediately. And I'm working with patients now who are completely blind and have had their colons removed. And let me tell you, are they furious? They are furious. So save the aloe for flares. It's okay. You got it. Keep it. Save it for flares. Hello, Phyllis. Karen says Bladder Builder on Amazon. Are you saying I may get rid of it on Bladder Builder? Karen, it depends upon what your phenotype is. We have to know what your phenotype is. If you've never heard the term phenotype before, that just means group. What patient group are you in? Because we're not all the same. We're very diverse. So if you are in the estrogen atrophy group, a chondroitin-based supplement could be all you need to get better. But you have to understand that estrogen atrophy is not a disease anyway. It's just aging, and so we have to adapt to aging. You guys, I work with patients every day. You're always welcome to call me during the week. The phone number, we have an 800 number, is at the top of our website, icnetwork.org. If you don't know what your phenotype is, I can walk you through the phenotypes and give you better questions to ask your doctor so we can really narrow down your underlying cause because we want to treat. Okay, so Karen says, my eyes are in horrible shape. Karen, how long have you been taking Elmeron? And are you having trouble adjusting from light to dark and dark to light? Some patients' eyes are changing in the first year. Others, it takes a decade for the changes to happen. Okay, let's go back to Facebook here. Ann says, I was on macrobid for UTI, never discharged, burning. Should I retest for yeast? Have frequency today. They told me to stop topical estrogen for now. If it persists, you should probably get a test. Rachel Ann says, I was given long-term macrobid, but I keep fighting it. Yeah, long-term antibiotics are definitely discouraged and not recommended. Karen said, you never took Elmeron. Okay. Sorry, hon. I can't. It's not easy for me to scroll back and look at other people's comments because I'm monitoring 3 platforms right now. But I'm sorry about your eyes, girl, because, man, my eyes are getting, I have one eye nearsighted and one eye farsighted. Leave it to me. So to be weird. So, and every year it changes and it's very annoying. And I've got computer glasses and I've got driving glasses and I've got reading glasses and it's wacky. Getting old is, in my heart, I feel 25. Dealing with an aging body is annoying. It's annoying. Okay, hold on. Let me go back here to Facebook. You guys, thank you for your patience on Facebook. And just know I can talk about pretty much anything, and you have to bear with me if I go off on a tangent. Diane says, I take PEA and it helps. I do need something else every day. So you take 160 milligrams of aspirin, and you're taking ibuprofen and maybe 500 milligrams of acetaminophen. I break the ibuprofen and acetaminophen in half. Acetaminophen is known for liver issues. Ibuprofen is known for stomach issues. There is a new medication that combines them both already on the market. I don't remember what the name is. I would encourage you to talk to your doctor and maybe get some liver testing to make sure that what you're doing is not hurting your liver. I just had a whole panel of blood tests. And they were all good. Oh, I don't like bad news. And I had my teeth cleaned, no cavities. Yay! The things we celebrate. Karen said, so eyesight going bad is from what exactly? Eyesight in IC patients, it's from the medication Elmeron. Other than IC is not known for causing eye issues. It's a medication that's known for causing eye issues. Karen said, is it an IC side effect? Is what an IC side effect? Yeah. Okay. Okay, you guys, just hold tight. Hold tight, my friends. All right. Shana said, any news on the Axonics device? No, not that I'm aware of. Bonnie says, Jill, you are a true hero. Thank you. See, guys, the problem with Facebook is it keeps jumping around. I'm happy to tell you your advice helped me arrange exactly the type of procedure I was seeking. My procedure is tomorrow, along with a biopsy and a possible tumor resection. I believe I have found an empathetic. You guys you get every time you type in Facebook, it jumps. So you got to bear with me here. Okay, hold on. Don't jump. Okay. She's found an empathetic physician who understands trauma and stress. Awesome. I'm glad, honey. Rachel Ann said her bladder was normal on cysto, just like mine, girl. So that's good. You got a healthy bladder. So what that means then is there's probably something outside of your bladder that's going on. You've been in pain for 16 months, researching that long. You're trying to find your personal trigger. It's not about finding your trigger. It's about understanding your anatomy. Have you had a pelvic floor assessment yet? And the question that I ask patients is, when your IC began, was there an event that you believe triggered it? Like, go back in time to when your symptoms started. What was happening back then? Did you fall? Louise said, I'm in a 3-day flare now. Nothing works to alleviate it. I just want my bladder out. 40 years of UTIs, pain. I want. Okay, so this brings up, oh, you guys, now I couldn't do my meeting last weekend. Oh, I have to take mental health days now. Just understand that I've been working 6 days a week now for almost a year. And there are some days when it's very hard for me to not go outside. So I'm doing my best to be here every Sunday, but there are times when it's difficult. Anyway, what have I been working on all summer? Our new flare guide. And this is the new one. So I had a preliminary review one about a month ago. This is it. I mean, this is the finished flare guide. It is in stock. It is awesome. 30 years of work. And so what makes this different, right? What makes this different? So this is our second book in our IC 101 series. Just so you know, Dr. Robert Eckenberg, the top pelvic pain doctor in the United States, wrote the foreword for the book. Okay. And I don't just cover bladder flares. We also do pelvic floor flares. We do stress flares. We do menstrual flares. We do urethral flares, vulvodynia flares, etc. And in each section, just to kind of give you a clue here. So here is our bladder wall flares. When you see my picture, this means that this is me talking directly to you and sharing, in some cases, some personal insight and personal experience that I've gone through. Then what we have are risk factors, because we go through the phenotypes, and the phenotypes will tell us what kind of flare you're prone to. And it looks like we're having an issue on Facebook right now. Facebook just froze. Great. We also have the common triggers. What are the things that are going to trigger these flares? And then we have hour by hour rescue plans. And so, for example, in the pelvic floor section, we have the stretches that you can do to try to get your pelvic floor out of spasm, etc. So if you're struggling with flares, the book is $9.99 as a PDF file, and I think it's $16.99, something like that, in print. And I'm going to tell you right now, it costs $9 to print it up. So paper has gotten very, very expensive because of the tariffs. All right. So, okay. So I don't know what's happening on Facebook here. Shoot. Has Facebook frozen? Deborah, thank you for the stars. Okay, we've got really good questions on Facebook, but it looks like it's frozen. No. Well, it says we have 22 viewers. Okay, so you guys, for those of you who are on Facebook right now, is your Facebook okay? Because it's frozen for me. But if you're saying it's okay, then that's good. So let me just go through. So let me just look. Diane says Facebook is fine on her end. Joanne says Facebook is fine. Okay. Christy says it's okay. So my screen has frozen, but I can see your comments. So that's good. We're going to keep going then. Okay. So let me go back here, because we got lots of good questions here on Facebook. Oh, you know what? It's jumping. It's jumping, 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 which makes it really hard for me to read it. Rachel Ann, is TMJ and migraines connected? Absolutely. That's part of the widespread pain phenotype. Welcome. This is my phenotype. This tells me that we're dealing with an old physical and or nerve injury or maybe some childhood trauma. Therapeutically, we're going to be doing things that calm your nervous system down and get your nervous system out of fight or flight. Patients who have multiple pain conditions, the classic thing we see is it massive anxiety disorder. I had terrible anxiety disorder myself when I was much younger. And we now know that that's driven by the central nervous system. It is not mental illness. Nobody is saying it's mental illness at all. It is actually an injured central nervous system. Lisa said, what do I make of the lactoferrin study when they added sodium bicarbonate and citrate to the lactoferrin? How do you know the results were due to the lactoferrin and not the sodium bicarb? Okay, well, number one, because it's a tiny, tiny amount of sodium bicarb. Number two, the only benefit the sodium bicarb is going to offer is it's going to alkalinize urine a little bit. What made the lactoferrin study critically important for us is that red inflamed bladders became pink and healthy, and Hunner's lesions almost completely disappeared. And more importantly, systemic inflammation and systemic inflammatory markers measured through blood testing decrease. Sodium bicarbonate cannot do that. Sodium bicarbonate is an alkalinizing agent that is added to treatments to help them get absorbed. That's why we have sodium bicarbonate in rescue installations. Now, so I don't believe that the sodium bicarb plays a significant role in it, and the citrate too. They're alkalinizing agents, but that doesn't stop the lactoferrin or doesn't trump lactoferrin's effect on boosting the immune system. And the research behind lactoferrin, you can go back. I have a blog on the front page of the IC Network. Yes, Phyllis, I'm on both. I've got a blog on the front page of the IC Network website that gives you all the research with it. And there's a lot of research that with lactoferrin that does not use the sodium bicarb that showed similar success in other conditions. My 2 cents. Also understand now that another company is selling what they call human lactoferrin, which is BS. It's made in a lab. When you say human lactoferrin, you're thinking it's coming from a human body. You can get lactoferrin from a human body. It is hundreds and hundreds of dollars. That human lactoferrin is actually made synthetically in a lab. And so it matches human lactoferrin, but it is not human lactoferrin. So I cry BS on that. It's, what's the right word for it? Bioidentical. It's bioidentical lactoferrin made in a lab. It's substantially more expensive than the cow lactoferrin that we get. And it's the cow lactoferrin that was used in the IC study. And so I say, you know what? I'd rather have natural lactoferrin, not made in a lab, that was actually used in the IC study that showed such good success. Phyllis says, I was diagnosed with IC vulvodynia lichen sclerosis. I've tried everything possible. My doctor just retired and I'm without help. Phyllis, so what's the connection between IC and vulvodynia? Nerves or muscles? So have you had a pelvic floor assessment? I had terrible vulvodynia when I was younger. Terrible vulvodynia. It's all related to very, very tight muscles squeezing the nerves of the vulva. You can call me and I'm happy to talk with you and see if we can find a doctor closer to you. Okay, let me scroll down Facebook here. Ann said she tried to call. I was busy. Honey, I answer the phone every day, but if I don't answer the phone, that means I'm working with somebody, so you always leave a message. Rachel Ann says her triggering event was a UTI, bacterial vaginosis, and ureaplasma. Okay, so bacterial vaginosis is normally a symptom of perimenopause, right? which means you're probably in some estrogen atrophy. And what happens is the pH in the vagina changes and it becomes more hospitable to lots of different types of bacteria. And so you would potentially be a very interesting lactoferrin patient, because lactoferrin was proven 3 years ago in boosting your immune system to fight off recurring infection, including recurring bladder infection. So lactoferrin could be a very interesting thing for you to try. I mean, it's worth a shot. Do your research. I got a great blog on the front page of the IC Network. You can read that blog, go right to the research studies and look at them yourself. Rachel Ann says, how do I know if it's pelvic floor? If you can't pee on command, if you hesitate 5, 10, 15, 20 seconds before you can relax enough to release urine, that usually means your muscles are tight. Is sex painful or is sex uncomfortable? Do you have pain? Do you have sciatica? Do you have pain that shoots down your leg? If you do, that's pelvic floor. And so if you look at our national guidelines, the American Urology Association guidelines for IC, the most important diagnostic test, which apparently you have not had, is a pelvic floor assessment. The urologist is supposed to check your muscles at the very first appointment. It's a finger in your vagina touching muscles. And if they're tight, you are to be immediately referred to physical therapy. That is a strong, absolute recommendation in the AUA guidelines. So we now believe that the single most important diagnostic test for IC at that first appointment is a pelvic floor assessment. And we know now that 85% of IC patients have muscle issues. So we're long past the days of telling everybody you'll have an incurable bladder disease. We know that that's not true, that most IC patients have tight pelvic floor muscles and or some other pelvic issue going on that's affecting the bladder. Some of you do have bladder issues, but a lot don't. And in my case, my symptom, I broke my tailbone when I was in 7th grade. My first symptoms started in 7th grade. I couldn't sit through class, kept having to pee all the time. And my urethra was very narrow because my pelvic floor muscles were squeezing it. Of course, we didn't know that back then, which is why I ate antibiotics like candy for a couple of years. Johanna says, I started physical therapy. She said, my right side is weak. She gave me exercises to stretch, told me I need to breathe better. She measured my back, legs, told me I would like to work on my C-section scar. She said, it doesn't look good. She said, inside physical therapy is coming. Excellent. Perfect. I'm so glad you got there. Excellent. Rachel Ann says, our biggest problem is determining your patient category. You're welcome to call me. We can go through it. Chris said, Elmeron and oxybutynin were horrible on my stomach. They can be. Yes, they can be. Jane is saying, you guys, I'm going backwards just on this list, just so you know. Flomax and Urogesic. Flomax is not listed. Neither one of them are listed as treatments for IC in the IC guidelines. They're very good examples of what I call chasing the symptoms. They're not going to fix anything. They're just chasing the symptoms. Flomax can help you pee, but Flomax is normally given to men with prostate problems, not to women with IC, although it has been for some. But if you're having problems urinating, we have to figure out why. Is it tight pelvic floor muscles? If it is, physical therapy could fix that completely. That is a heal. Sabrina said, what do I think of Flomax and oxybutynin chloride? My urologist has on me on these drugs for bladder pain. So again, Flomax can help you urinate. Oxybutynin, also known as ditropan, is a tricky medication, Sabrina, because it is an anticholinergic medication, and anticholinergics have now been linked to dementia and cognitive decline. So if you're over the age of 60, they generally would not give you an anticholinergic med because we want to try to preserve your cognition. So instead of oxybutynin, most IC patients are given Myrbetriq, Myrbetriq, or Mirabegron. does the same thing. It helps calm the alpha afferent nerve, reduces frequency urgency, but it does not come with that same risk of cognitive decline. So again, Sabrina, I can't tell how old you are, but I only used oxybutynin for a couple of weeks. Okay, let me take that back. Let me think about this for a moment. What did they give me the first time? Okay. They gave me a medication like oxybutynin. What was that? I mean, this was 30 years ago. So what happened is it kind of deadened my bladder and it made it difficult to pee. And because I felt better after peeing, making it more difficult for me to pee was not a good thing. And so I only lasted a brief period of time. Then, I don't know, a couple of years later, I had a very, very bad bladder infection. I didn't know it was an infection. I thought it was a flare. Hi, Joanne. Whoops. And so, I had this fairly wicked infection, wicked flare, didn't know it was infection. 6 weeks later, I was having what I kind of bend over and screamer bladder spasms, where I would go to pee, and as the last couple of drops came out of my bladder, it bent me over the toilet, and I couldn't move for about 5 minutes. Really violent spasms. And I literally drove myself to the urologist's office and walked in crying without an appointment. And they had never seen me do that. I ran the IC support group for Kaiser Permanente here in Northern California for like 10 years. They had never seen me cry. And so as soon as I walked in bawling my eyes out, they pulled me, the nurse pulled me back into her office and it's like, "What's wrong, Jill? What's wrong?" And I described this violent spasm, and I said, "I've never had this before." And she's like, "Don't you know what that is?" I'm like, "No, that's a bladder spasm. Let's get a urine sample." And it turned out I had this massive infection. So they gave me oxybutynin, and within 30 minutes, it turned the bladder spasms off. So I used oxybutynin just for a day or two. And then I stopped because I knew I wanted to be able to urinate. Okay. Oh, deep breath. You ever have those days where you wake up and you're just like, I was out all day yesterday, all day, doing an art trails event. And this morning it's like, God, I want to go do art again. But my brain and my body was going, no. And I forced myself anyway. And I went out at 10 and hung out for a couple of hours with some artists before I came back to do this meeting. It was very good for me to do that. Okay, I need to pee. Anybody else need to pee? Let's take a pee break. All right. On a scale of 1 to 10, I give that pee break a 9. That means my pelvic floor is doing good today. All right. Hello, Les. Nice to see ya. My neck is so freaking tight. Oh, if you ever see my head go start doing this, that means my neck is really tight. And I have been doing so much computer work this week. Okay, what have I missed? So again, if I missed a question, ask it again, especially if you're on Facebook, because it just flashes by like nobody's business. Rachel said she's premenopause, long hauler, nerve sensitivity. Welcome, girl. Me too. Yeah, throw in breast cancer to my story. Chris said, my OB doctor prescribed vaginal estrogen suppositories, but the pharmacy gave the applicator inserts. Do I know if one is better than the other? Are you talking about a cream versus a vaginal insert pill? They're fairly equitable. The cream is preferred though because you have more flexibility on where you can put it. Because, like for me, with my estrogen cream, I rub it at the entrance to my urethra. That's my prime. That's where I feel estrogen atrophy is in my urethra. It feels like it can feel like there's a drop of urine stuck in my urethra that won't come out. So, so the cream is preferred. Some people think it's kind of messy. I don't think it's messy. Hello, Nicole. Hey, Nicole Kosian. Girl, long time no see. So we're just doing a little IC support group meeting on Sunday. We're streaming on Facebook, on YouTube, and on Instagram. And basically taking questions. And so Nicole is a pelvic floor physical therapist who was our physical therapist of the year about 5 years ago. And oh, thank you, hon. She said she wanted to say hi. Let me get your book. Hold on a sec. So Nicole is the author of the Interstitial Cystitis Solution. And one of several books that we suggest and recommend. She's a practicing physical therapist down in Southern California. We send a lot of patients her way. And it's just a lovely review of what your options are. Nicole, my question to you is, are you going to update it based upon phenotyping? Because now, you know, with the latest AUA guidelines, you know, the very first thing they're saying is you have to phenotype first. Henry Lai taught the class at AUA this year with Quentin Clemens and Anne Ackerman, Anne Lenore Ackerman at UCLA. And so their entire point of the class on IC at AUA was a phenotype first, use phenotyping to establish treatment priority. Oh, Nicole says, yes, your practitioner course is already updated. Yes. You know, because I mean, like, honestly, I feel, number one, I'm really frustrated because we still have right here in this meeting, like literally 30 minutes ago, we had a patient who had never had a pelvic floor assessment. And if you look at the AUA guidelines, it's like test number one now, aside from a urine culture. That's number one, is to check that pelvic floor. If that pelvic floor is tight, refer them to a physical therapist like Nicole Kosian. Go have a proper pelvic floor assessment to understand the landscape here. We have to understand your anatomy more. It's all about anatomy. And it's all about understanding that muscles and nerves impact bladder function. They do. They do. And the interesting thing too, to be quite honest, is, oh God, who was it? A lot of our top IC docs are getting close to retirement. So I won't say who it is, but it's a very famous IC doc who's now retired. And we were texting a couple weeks ago, and he said that physical therapy has become the new Cipro for urologists. Okay, so that was interesting that now they're saying that urologists are maybe referring a little bit too much. I disagree with that. I think every patient needs to have a pelvic floor assessment. But getting doctors to actually read the guidelines and make that referral is just really, really difficult. Nicole says, and we need to do a book update. And Nicole, hey, listen, if I can show you what I just finished, it's our new flare guide that talks about bladder flares, pelvic floor flares, neuralgia flares, stress flares, urethral flares, menstrual flares, vulvodynia flares. And it's the first one that discusses the risk of flares based upon phenotype. So, for example, that Hunner's lesion patient is going to be the most prone to bladder wall flares as compared to the widespread pain patient, right? The widespread pain patient, we're dealing really more with central nervous system, anxiety-driven, amygdala-driven issues, things like that. And so so I've got triggers and rescue plans. Thank you, Hun. Thank you. I try. What I'm really happy about, though, is that because, these are like 5 pages dedicated to each type, right? So it's not like we have a lot of space, but like in the pelvic floor section, we go through all the stretches that a patient who's currently in a pelvic floor flare can do, or positions to try to calm things down. And then lots of articles in here on spouses, the critical role that spouses play, and flares while driving, flares with sex. Great discussion on intimacy and the differences between men and women who flare with intimacy, and learned all sorts of interesting things about the pelvic floor in men. We need a lot more resources for men, a lot more. So anyway, nice to see you, Nicole. Hello, Gail. Nicole says, and the outcome measure I use the most for central sensitization phenotype is the CSI. So important for every patient with IC to take with their pelvic physical therapist. Yeah. Hi, Sander. Oops, hold on here. Phyllis said, okay. Yeah, I didn't talk about, there are a couple of different things. There's another really cool sensitivity testing tool I could have included. I just didn't have the space. The problem is that paper is just too expensive now. Doing printed books is, you're lucky to break even at this point in time. So we can only go so far. All right, let's see here. Okay, so for those of you on Facebook, my screen has frozen, and now my messaging has frozen on Facebook. So if you're on Facebook, could you write something in the comment area? Because I think I'm dead in the water now with Facebook. You can come over to YouTube. You can come over to Instagram. Normally, guys, we go 2 hours. We've been going in an hour and a half so far. I'm here at your pleasure. Some of our meetings go for 5 hours. Some of them go for 30 minutes. Joanne says it's still good on Facebook. Okay, Joanne, I'll take it. I will take it. Let's see here. And Sabrina says it's working too. Excellent. Hi, Margie. Karen says this has been so helpful. Thanks, guys. Thank you, Karen. You are welcome. You are absolutely welcome. And don't forget our book, IC 101. It's not just a bladder disease, which is the first book to ever talk about phenotyping. And I will be updating that next year. So our IC 101 series is our main IC 101 book. We have our IC 101 masterclass. It's free on our YouTube channel and on our website. Then we have our IC 101 flare guide, and I have on my computer right here our new IC 101 diet guide. And then I'm working on, let me ask you this. Okay, because I want, granted, I've been doing this a long time now. We have a ton of freebies on the IC Network website. We have medical records kit, you name it, we've got it. Lots of free articles, lots of free fact sheets. Our website's entirely free. It's always been free. You don't have to pay $500 a month to somebody to teach you about IC. I will teach you about IC. We will teach you about IC. And the IC Network has been rated the most accurate and reliable, credible website in 2 peer-reviewed studies, one by Harvard, one by the University of London. I am an IC researcher. I have helped to allocate millions of dollars in IC research. And I was just asked again by the US Army to do some more work last week. So, this is not, there's a big scientific foundation in what we do. Okay, so hold on a sec. I want to show you what I'm working on. The other thing, and you can tell me if you think I'm nuts. So hold on a sec. Okay. So the other thing that I'm working on is called our IC 101 Medical Journal. Because you would be amazed at the number of patients who call me and we're coaching and it's like, okay, well, what they put in your bladder, they don't know. Like they have no idea what treatments they've done. They have no idea what worked. They have no idea what tests they were done. And the biggest challenge with interstitial cystitis is that some doctors are taught in medical school that it's not real. And this goes back to the 50s. Believe me, IC is real. We put $100 million into IC research through the National Institutes of Health. And yet there is this perception that interstitial cystitis patients are annoying and frustrating. And urologists have said they don't want to work with IC patients because we're demanding and they can't do surgery and they want to do surgery. Anne says, do I know anything about estrogen causing pelvic congestion syndrome? The answer is yes, absolutely. Pelvic congestion syndrome is real. It's basically varicose veins in your pelvis that can affect your bladder. So if you have typically somebody with pelvic congestion syndrome, they sleep well, they get up in the morning, and as the day goes on, they get a heavier and heavier weight in their pelvis until by the end of the day, they feel like they're carrying a bowling ball around. And then it repeats. You go to bed, it goes away, and then the next day you wake up and bam, that's blood accumulating in these varicose veins in the pelvis. That can be treated, thankfully. Kayleen, girl, had to take her mom to the ER for a possible concussion. Holy hell. Is she okay? Give her my best. Okay, let's go back to this. You guys, I want you I want you to credibility test what I'm working on right now. So this is a medical journal that you'll be able to get its PDF file and you can print it out, or I will print it up. And the goal here is for you to have a medical kit that you can take to every doctor's appointment. So let me show you what's in it. Okay. Hold on a second. I got it all. It's this big, big project. Trying to create something brand new that's never been done before, because that's my jam. Okay. So in this, the first thing we talk about are phenotyping to help you understand what your phenotype is. It's okay, Sander. Then I have your medical directory where you're going to list all the doctors you see and have seen in the past. And I want you to write down why you stopped going to a certain doctor. That's important information. And if you ever have to apply for Social Security, having the list of your doctors that you've seen are important. Also has your pharmacies. Okay. Actually, that's the old one. The new one is my medical team. So we've got your urologist, your primary care, your gynecologist, your physical therapist, and more. Okay. And then we have doctors you no longer see. Our next section is diagnostics, the different tests. Now, listen, if somebody's watching this and you're thinking you're going to do this before me, stop it. My idea. Okay, in this, I've got cystoscopy results. Have they looked in your bladder? What have they seen? And then we have pelvic floor assessment. So what did they find with the pelvic floor? Did they find trigger points? What treatment plan did they propose? Physical therapist name, all that sort of stuff. I've got a section for urine tests, all your urine tests, because y'all have had a ton of urine tests. And eventually, when you see you've had 20 urine cultures and they've all been negative, maybe you can stop getting those urine cultures and save your money. I have got Hunner's lesions area, Hunner's lesions treatments. So basically what I did is I took a log I created 20 years ago, and we're just trying to make it better. Pelvic floor therapy log, support log, emergency care log, pain diaries. And the piece that I think is the most important is this, which is a physician appointment log. And you should just have a log for every damn appointment you go to, because this is important information for you to track over time and to share with another doctor. So it's, why did you make this appointment? What symptoms were you experiencing? Make a list of the questions you want to ask the doctor. What action did the doctor want to do? Were lab tests suggested? What treatments were suggested? What's the follow-up? Would you like to see that doctor again? Okay, so I'm playing with this. You don't see me. You're not seeing me in any of the IC groups online right now. I just want to make things right now. So I'm producing things right now. Hello, Harville Denise. Hello, Helen. Loves the beach. Okay, hold on. Let's go back to Facebook here. Kayleen's mom, they took her back for a CAT scan. She's okay, but we're going to play it safe. Smart thing to do. Caddy says, how does a vaginal prolapse affect IC? Well, it depends upon the direction of the prolapse. So with a vaginal prolapse, that means the vagina is falling. It is moving out of position. And there are moments when the vagina flops forward on top of the bladder. And it can even actually start pushing the bladder out of position or bending the bladder. which can make it difficult. It's going to cause a lot of issues. So there's a lot of different ways that a vaginal prolapse is going to affect the bladder and affect IC. If you and also too, we've now linked the uterosacral ligament. If that's stretched out as the underlying cause of vaginal prolapse, we also now know that that can cause Hunner's lesions because a nerve gets displaced. So if you got a prolapse, you got to deal with it. Now, the question then gets raised about pessaries. Now, understand that as we get older, our muscles can get weaker with the loss of estrogen, which can kind of create a foundation for muscles getting weak and starting to prolapse. Even the urethra can prolapse. You can get something called a urethral caruncle, where part of your urethra slides out of your body and it gets very painful little lump at the entrance to your urethra. It's another thing that can happen with aging. I forgot the point I was going to make. Sorry. It'll come back to me. I'm 65. What was I saying? Okay, it'll come back to me. What was I going to say? Okay, so, oh, I know, pessaries. Pessaries. Okay. If it's a mild prolapse and it's just starting to prolapse, physical therapy can help. And that's when you want to go to physical therapy and strengthening muscles, because there comes a point in time when if the prolapse continues, you start to stretch out the muscle to the point that it cannot respond back. And that's a yikes situation, because now we have a stretched out muscle that physical therapy can't help. And our first intervention is going to be a pessary. Now, pessaries are weird. Pessary is a structure that you put in your vagina that basically holds everything in place. There are a lot of different sizes and shapes of pessaries. Some are comfortable, some are not comfortable. Some you put in and take out yourself, others the doctor puts in and takes out. I share this story frequently when I work with patients on the phone. One of my oldest clients, who I think I met her, she must have been in her late 60s, early 70s, and I knew her all the way to her mid to late 90s when she passed away. She had a mild prolapse in her 70s, and she was afraid of the surgery. And so she went with the pessary, and she came to hate that decision, because what happened is as she got older, the muscles just got weaker and weaker and weaker. And then she got too old to have the surgery. They wouldn't do it. And so at the end, before she passed away, she had the ickiest, most awful pessary that they kept in her for 6 weeks at a time. Then she'd have to go to the doctor. They'd have to pull it out and clean it and shove it back in there. And the last time I talked to her, every time I talked to her, she was so angry at herself for letting fear stopping her from getting the surgery that could have prevented all this from happening. So, Katty, the point that I'm trying to make here is we have to know the degree of the prolapse. If it's super, super mild, man, girl, dive in. You got to dive into physical therapy. Let's get these muscles as tight and as strong as possible. But if you're kind of past the physical therapy point, you've got to have that discussion about pessaries. But at the same time, you got to have that discussion about surgery. The reason why I opted for a double mastectomy last year when I was 64 is I didn't want to potentially have to have it when I was 74, because I had cancer in one breast, but not the other. But if you look at the research, you see that the cancer often appears in the other breast 5 or 6 years later. I thought, you know what? I'm young now, comparatively. I'd rather have the big surgery now when I'm younger. And that was one of the lessons that I learned from that patient. So be willing to have that discussion. Not the easiest surgery in the world, but there are pros and cons with everything. And if you ever want to talk about it, just give me a phone call. Anne said, estrogen is hormone replacement therapy. I've used HRT for 20 years and I cannot use HRT. What can I do or use instead of estriol to support atrophying of the bladder wall? Well, and when you're saying, and you say, due to my pelvic congestion syndrome, you have gonadal vein embolization and a balloon placed in your iliac vein. They suggest an appointment with an interventional radiologist who may work with a vascular surgeon. The interventional radiologist doctor did my procedure. Excellent. So, do they not want you to do? Okay, so you're using estrogen as hormone replacement therapy. Were you doing it orally or were you doing it as a cream? I mean, and if you're doing it as a cream, did they want you to stop doing it as a cream because of the pelvic congestion syndrome? This is not my area of expertise, so I don't know the protocol for treating pelvic congestion. Okay, so you've been using the cream. And why did they tell you you had to stop it? That's interesting. Hi, LJ. So I'm Jill Osborne. I'm the National IC Support Group Leader, and we're doing an IC Support Group meeting right now. We're doing it on 3 platforms simultaneously. We're doing it on Instagram, and we're doing it on Facebook and YouTube. So we've got groups of patients everywhere. But we're near the end of the meeting, just saying. Oh, you had to stop because of the pelvic congestion syndrome. Interesting. I wonder why would estrogen affect a vein? Yeah, I know. I mean, again, I haven't studied this, and we've only just in the last year or two started having um, uh, um, interventional radiologists speaking at pelvic pain conferences. So believe me, I have not researched this at all. Pelvic congestion syndrome, estrogen. I'm just curious. What did they say? Estrogen contributes to pelvic congestion syndrome by dilating blood vessels, making the veins in the pelvis more susceptible. Okay, makes perfect sense. I didn't know that. This is supported by the fact that PCS is uncommon after menopause when estrogen levels decrease, and it often affects women between the ages of 20 and 45. Interesting. Learn something every day. Interesting. I'll have to read up on that. All right. So, what do you think of my medical journal idea? Would you use it? Like, if you can download it for free on our website and just print it out, would you use it? Just trying to create as many resources as we can. Kayleen said, could I possibly have pelvic congestion syndrome if I have vaginal varicose veins? Yes, you could. Joanne says, good idea. Yes, you'd use it. Cool. Kelly says she would use it. Cool. Like I mean, I got to be really honest here. I don't read IC groups online anymore. I find social media in general to be very poisonous. It is especially for me the last couple of years. I have to take responsibility for what's coming into my soul right now because I was in deep grief, and then I got cancer, and I had 2 surgeries. And I recognize now that I am more fragile than I was 5 years ago. That I feel emotionally worn out by the trauma of going through what I've gone through. And I have moments when I cry fairly frequently. I mean, not every day, but a couple of times a week. In fact, today I was at my church and they were doing a little Christmas fair, and There's a sweet little lady who was selling. Oh, let me get it and I'll show it to you. Hold on. So when you have cancer, you're immediately thinking, I'm going to lose my hair. And obviously I haven't. And obviously I'm growing mine out as an FU to cancer. Excuse my language, but that's how you feel when you've been faced with this horrific diagnosis. And so while I was waiting for my surgery results, I was planning on cutting all my hair off and shaving my head to go into chemotherapy. And I thought that I would be wearing hats like this over my bare head, right? So this is kind of what I imagined that I would be wearing while I was going through chemotherapy. And, and again, thankfully, I didn't have to go through chemotherapy. My lymph nodes were clear. So anyway, I was at this craft fair, and there's this 85-year-old woman who's making these. And it turns out like we're almost related. We're both Norwegian from the same part of Norway. And it's like, I felt like I was talking with my grandmother, and her name was Betty and my grandmother's name was Betty. And we just both burst into tears. It's like, oh my God, you're my grandmother. And she was like, oh my God, you're my daughter. And it was like the most wonderful, wonderful moment because my grandparents and my parents are gone. And so we had a good cry. We just felt instantly connected. So anyway, $15, she made these hats. So I bought 10 of them and I'm going to give them away as gifts. So here's a yellow one. See, that's pretty cute. Right? Like I would totally wear this one. And then here's a green one. So I'm going to be like my grandma Betty, who used to give funky gifts to all the nieces. Okay, that one's weird. And my nieces and nephews, they're all going to get these funky hats. Here's a blue one. Here, hold on a sec. I look like a nut. Anyway, we were both bawling our eyes out. And she's like, you're my daughter. And I'm like, oh my God, your name is Betty. You're my grandmother. And then we both started crying. And she goes, that's a Norwegian thing to cry. I'm like, oh, I thought it was a cancer thing. Look at this one. This one's really pretty. Khaki. This one's really pretty. What do you think? Cute. Okay. Okay, so I'm here as long as you have questions. But I think we have come to the natural end of this meeting, my friends, which is fine by me because I can go paint. Okay, so hold on again. Anne says, starting to have bladder wall burning, needs some type of support now. So the bladder wall burning, Anne, is probably just estrogen atrophy of your bladder wall. And so that's where you're going to want to do something with chondroitin, like a bladder builder, which can give you a little bit of extra protection on your bladder wall. Not aloe. Aloe is not going to help. We're looking for something that is hydrophobic, that will push urine away. That's chondroitin. Chondroitin is a building block of the bladder wall. If you have burning on the outside, then you want to do Vulva Balm. Vulva Balm is wonderful. So if you're starting to get dryness on your vulva at the entrance to your vagina, vulva balm it's an organic olive, avocado, sea buckthorn oil. It's a very, very light. It mimics your normal mucus. It's not messy. You could use coconut oil too, but coconut oil soaks through everything. This does not. So vulva balm, I suggest to virtually every estrogen atrophy patient. This is my personal bottle. I use it too. This will last you. It's like $26. It'll last for 6 months or longer. It's a good product. Kayleen said, I'm definitely going to ask my urogyno on Wednesday. I know during even the easiest bowel movements, my clitoris and vagina feels full. That would be a really good question, Kayleen. I mean, you definitely have blood flow issues going on down there. There's no doubt about that. It's just you're young, you know? I mean, you haven't had children yet. So, and it's having children that can be an issue. Anne says, chondroitin sulfate worked for me years ago, but you can't find it anymore. Chondroitin 4 sulfate. Well, these all are based on chondroitin sulfate. These are all chondroitin sulfate products. Bladder Builder, Bladder Rest, Cystoprotect, Cystomen. I mean, and these have been used by thousands of patients for years now, successfully. So let's see. So hold on a second. You're saying chondroitin 4 sulfate. It's a specific type of chondroitin sulfate. A separate line of research indicates that chondroitin 4 sulfate may promote the growth of melanoma cells. They say mixed results, especially with long-term use. Common side effects, nausea, diarrhea, stomach upset, headache, may interact with blood thinners like warfarin. I understand that there are different types of chondroitin sulfate. But see, the thing is, Anne, is that I don't know anybody who would tell patients just to take chondroitin. Pretty much all the chondroitin supplements have other synergistic ingredients that are designed to fight a number of different things. So the chondroitin is the foundation. Then we got quercetin for its antihistaminic effect. And depending upon the supplements, like Bladder Builder had some beneficial probiotics for the gut, and it has PEA in it to reduce pain. Cystoprotect combines it with hyaluronic acid. The bioavailability of hyaluronic acid is terrible, so I think it's kind of pointless. A Cystomen throws in a little bit of aloe, a little bit of D-mannose, a few other things. Anne says, quercetin burns your bladder. If it's straight quercetin derived from bioflavonoids, if you were just buying quercetin from Amazon, I can almost guarantee you it came from citrus. So I'm not surprised that a quercetin by itself burned your bladder. You have to get quercetin from the Sephora plant, not from citrus. Bet you didn't expect that answer, huh? Kayleen says, I think my kidneys are really messing things up. My vulva has been dry and burning. This Urogyne appointment was just supposed to be routine follow-up, but now it's for 2 post-hospitalization. So Kayleen, again, for you, girl, this would be you know, important. Something like this that would give you a little bit of protection down there when your vulva is dry. It's not water, it's not KY. You don't want something that's water soluble. The natural mucosal layer of your skin down there is hydrophobic. It is an oil base. It needs to be slightly oily to push water, to push urine away from the skin. Vulva Balm is going to be one of the closest you're going to find to that. And it is this. I'll type it out for you. See, if you buy all the ingredients individually, you run into two problems. Number one, you're going to end up with 4 or 5 supplements that are each going to have a variety of price levels. You would never go with the cheapest stuff because it's basically cheap stuff from China that's testing has shown often doesn't contain what the label says it contains. So we always want to go mid-level or slightly higher, or we always go with an organic source, which then brings your monthly bill up substantially. So the advantage of going with the formulas that were created specifically for bladder issues like Bladder Builder or Bladder Rest is the best ingredients in one supplement, and the price point is much, much better because you don't have to buy 4 different supplements. You just buy one. Well, hello, Donna. I was wondering where you are. I hope that your mother-in-law is doing well. Hope you're doing well, hon. We're just kind of getting to the end, near the end of the meeting. I can't wait to talk to you. When you're up for a talk, give me a phone call. Karen says, are you recommending Vulva Balm for sexual intimacy or general health of the vulva? General health of the vulva. And you can use it for sex, but it's not designed for that. It's not a lubricant. It is more a skin aid. So I think I use Vulva Balm and I use KY. If on the rare occasions I have sex. Donna says, all right, girl. So Karen says, will Vulva Balm help with IC? It will help with skin sensitivity in your crotch area. Over here, hold on. There you go. Donna, that's for you. Or this. Ouch. Melly says, is there a time when you always pop in? Usually around 1 o'clock Pacific. And says, problem is I cannot tolerate one of the ingredients in Bladder Builder and Bladder Rest. Not sure what ingredient burns my bladder internally. Huh. I've got one other patient I've worked with who has the same issue. Let me see if I can remember what it was. Was it the L-arginine? It would have been either the L-arginine. I think it was the L-arginine. I'm trying to remember. Hold on. So this is Bladder Rest. So Bladder Builder is like the top supplement, and it's the top supplement on Amazon too. It's very popular. The reason why this is the top supplement is because it contains PEA also for pain relief, and it's got like 4.5-star reviews. It's our biggest seller by far. Bladder Rest is kind of a simpler formula for patients who are more sensitive. So it doesn't have all the extra ingredients in it that Bladder Builder has in it, but it's got D3, K. Sorry, I don't have my reading glasses on. K2, and then it's got the same chondroitin, L-arginine, quercetin from the Sephora plant. So okay, so again, and I've had one other patient I can think of, same issue, and we just pushed her over to Cistro Protec, and she tried the Cistro Protec and she tolerated that. And this is important. L-arginine instigates her oral herpes. I have oral herpes too. You are right. You are right. Arginine can help viral infections grow. Lysine helps stop viral infections from growing. And so this is why I love super lysine chapstick. I have a lot of chapstick and I've got lysine drops for moments when my canker sores decide to visit me and taunt me. You know, and anybody who's had COVID, you know, it would be smart to not be on L-arginine during COVID. Denise said, I'm so confused. I had one urologist tell me I have IC. Another one told me I don't have it. I have very light flares, but mostly I feel good. Just wish I had a definitive diagnosis. Your cystoscopy shows nothing. But Denise, okay, your cystoscopy showed nothing. That's great. So stop using the word interstitial cystitis. Most of the world is not using that word anymore. You are a pelvic pain patient. You have pelvic pain syndrome. So our job now is to try to understand what's happening in your pelvis that's causing the pain, that's victimizing your bladder. So anytime anybody has a doctor who's like backing off and it's like, oh, you know, you don't get respect when you say you have interstitial cystitis or an IC flare. Just stop using the words interstitial cystitis. Just say you've got pelvic pain. That opens up doors that IC closes. Karen said, are hemorrhoids common with IC? They're common. Hemorrhoids are common with pelvic floor dysfunction. If your muscles are tight, it's hard to relax your muscles to release urine and to release bowel movements. And so what happens is IC patients start to strain, pelvic pain patients start to strain. And as you strain to push out bowel movements, you pop a hemorrhoid. So it is common. So if you have hemorrhoids, odds are you probably are straining, which means you probably have pelvic floor dysfunction. Karen said, bought the bladder builder. Cannot believe I didn't know about it. Girl, yeah, it's okay. You know, I mean, this is where you have to understand that a lot of the information you get online is being driven by companies trying to sell you something. I hope you know that I'm not trying to give you a sales pitch on anything. I'm just showing you options. You've got to do your own research. And it all begins with your phenotype. If you're pelvic floor driven and you have a normal bladder, you probably don't need to be taking any bladder supplement at all. The only supplement that would make sense is PEA to calm any nerves down that are being irritated by your tight muscle. In contrast, if you have Hunner's lesions, what the research says is try lactoferrin. And we got a good research study showing lactoferrin healed Hunner's lesions. If you've got recurring UTIs, lactoferrin or prevent would be the suggested pathway there. Hello, you guys. Jill from the IC Network doing a live support group meeting for anybody with pelvic pain, bladder pain, prostate pain, urethral pain, rectal pain, vulva pain. Oh boy. Who knew? Who knew? And by the way, for anybody with IBS, irritable bowel syndrome, you should sign up for, if you go to helpforibs.com, Heather Von Voris has a fabulous, fabulous e-newsletter. Little daily smidges every day that I swear are teaching me. So she's taught me everything I know about IBS and has been remarkably helpful for me in getting rid of my IBS. I don't have IBS now like I used to. Diane said I've had two. Oh, wait. Okay. Diane said I had two different doctors do cystoscopies. One said I didn't have Hunner's lesions, and the other said I did. Diane, did they take pictures for you? Do you have pictures of it? Anne says she uses Dr. Bronner's Naked Organic Lip Balm to prevent oral herpes. See, the problem is I get canker sores because I bite my lip because my jaw, my TMJ is weird. And so every morning I have to push my jaw into place. A ligament or something moves out of position every night and I got to push it back up into place. And so because of that, I bite my lip and that's where I get my canker sores. So lip balms don't do that, but I will do super lysine on the inside of my lip sometimes too. Diane said the second did, but just cloudy gray colored. So I'm black and white. What? What was gray colored? Your bladder is kind of pink. Joan said, who's the person to research for help with IBS? Here, I'll give it to you. Heather Van Voris and helpforibs.com. She's so good. I mean, I look at what she's doing, because our model for delivering support is different. There were 3 health websites that got started in the earliest days of the internet. The IC Network, Help for IBS, and History Sisters. And we all became friends. And what was interesting is we all went in different directions because we all had limited money. So I went for support. And so I put that little bit of money that we had into creating this giant support forum that we had for many, many years. And we did live meetings and live support group meetings, but it was all text back then. We had over 100 live events and I was writing books and stuff like that. Heather at Health for IBS was creating products. So she created the Heather's Tummy Fiber line, a product that we sell in the IC Network store, a soluble fiber, very gentle for anybody who's got IBS. If you got IBS constipation or diarrhea, the acacia fiber is spot on good. It's what I use anytime I might have issue. And then History Sisters, they put their money into technology. So we were doing more research and support. Well, let's see. We were doing more research and writing and educating. And yes, we had our forum, but like we wrote some of the first books. We wrote all the web materials for IC originally. We wrote the first diet list, all that sort of stuff. Over at Kathy, over at History Sisters, she put all her money into technology and she created this incredible website with all these apps. I mean, I did apps too, but I think she had a lot more money than I did. So now she's gone. She sold her company. Heather's company is being challenged by the fact that the organic acacia they get comes from Africa, and it's being affected by a war in Africa. So they're struggling with the supply line for acacia right now. And I'm like the persistent, it's hard. I mean, I'm just persistent. It's just like, yeah, I'm just going to keep doing this. Denise said, next visit will be with a urogyne because vulva is burning, sometimes involved, and I do use your hormone cream. But see, you can only use your hormone cream 2 or 3 times a week, but you can use vulva balm every day, twice a day, if you need it. This is what you add to your daily routine, and it should help tremendously with the vulva burning. It helped me tremendously with my vulva burning. So I would consider investing in 1 bottle of this. It's like $26, $26.99, something like that. It's right in the IC Network shop. Just go to our website, icnetwork.org, click on shop. It's under feminine hygiene. Give this a try. Worth playing with at least. Oh, Diane, so your doctor gave you black and white pictures. Well, that sucks. The second doctor did steroid injections in your bladder 7 months because he said I had lesions, and I'm scheduled to have that done again in 3 weeks. I don't know if I want to do that or not. Well, listen, if they were injecting a steroid in your bladder, that means that you probably did have Hunner's lesions. So the question is, how did you respond? Were you better? Did they help? It would be very interesting for you to try the lactoferrin, because the lactoferrin study that was released last year showed that red inflamed lesions and red inflamed bladders became pink and healthy, and Hunner's lesions virtually disappeared in most patients. Simple over-the-counter supplement. Lactoferrin is not a chemical made in a lab. It is isolated from cow's milk. Lactoferrin is an essential protein in our immune system. Our body makes lactoferrin. We have lactoferrin in our tears. We have lactoferrin in our vaginal fluid. Lactoferrin also has anti-cancer effects, which is why they say that not breastfeeding increases your risk of breast cancer. Women who have breastfed have a lower risk of breast cancer, in part because of lactoferrin. And so it is considered a front line of defense for your immune system. And again, it comes from cows. It's not made in a laboratory. So it would be, the IC study showed no side effects. 28 out of 31 patients had no symptoms when they stopped after 4 or 5 months, and their bladders healed. So that would be something fascinating for you to add to the mix as an experiment. You've been on lactoferrin for 9 months. Excellent. And you think it's helped too. Okay. So at this point in time, I think the question you have to ask your urologist is, how do the lesions look? Am I better? Because if your lesions are known to heal, so if your lesions have healed, then you wouldn't need steroid injections anymore. So it would be reasonable to have that second hydrodistension that they're going to do in 3 weeks, just to get a looky-loo at your bladder and see how your bladder's doing. And if your bladder's doing better, great, excellent. That's wonderful news. Phyllis says you can't get it. Oh, where can you get it? It's in the IC Network shop, hun. It's right on the front page. It's called lactoferrin. Just go to icnetwork.org and click on shop, and it's right there. There's a lot of lactoferrin on the market. There's cheap lactoferrin. There's super, super expensive lactoferrin. The lactoferrin that we get in the IC Network shop is the same lactoferrin that was sourced for the IC study. Not exactly the same, but they both come from Australia. And so that's the one that now probably a couple thousand patients are using. And it's helping quite a few, and others it's not helping. And I think, again, that depends on phenotype. Lactoferrin is not going to help tight pelvic floor muscles. Lactoferrin could help inflammation in the bladder. All right, guys. Well, listen, I think we're done. I hope that you have, hey, you want to see my Halloween costume? Oh, hold on a sec. Peggy says, you're off of Elmeron. I'm 80% better. It also helped. The lactoferrin also helped IBS and stomach issues. So glad you gave us the information. Yeah, baby, that's what I want to hear. This is great. It's helping so many patients now. Worth a shot. In part because the doctors, you have to understand that the only FDA-approved oral medication for IC-Elmeron's linked to blindness. So that's pretty much off the table for most patients. They want to save their eyesight. But, bladder installations are not particularly helpful. The one therapy which we have great research on is physical therapy. That works for almost every patient who does it. But now we've got some other things. Now with phenotyping, we're understanding kind of the nuance, and we can treat the nuance with some of these specialty supplements. Phyllis, just go to the IC Network website, and there's a contact form, or my email address is really easy. It's just icnetwork@mac.com. That's short for Macintosh computer, icnetwork@mac.com. Feel free to email me. Everybody out there, be the squeaky wheel. You got to understand, I get hundreds of email a day. You can do it in all caps. You can put the subject title in all caps. It's okay. And if I don't respond to your mail, then call me. Calling me is always better. If I don't answer, leave a message and I will call back when I can. Make sure you have your voicemail set up. Somebody called this week who didn't have their voicemail set up and I couldn't leave a message. Phyllis says, can I recommend a doctor in my area or would I travel? It depends upon where you are and what your phenotype is, so call me. Because if you're pelvic floor driven, we're going to go to a physical therapist. If you're an estrogen atrophy patient, you're going to go to a gynecologist rather than a urologist. So knowing what your phenotype is going to help tremendously. All right, guys, if you find these meetings helpful, please come on over to the IC Network, become a member. You can get our wonderful magazine, the IC Optimist. And don't forget now our brand new book, The Flare Guide, is now available. It's in the book section of the IC Network store. And I really think it's going to help. 30 years worth of tips in this book. All right. I'm going to say goodbye to Instagram first. Bye, you guys. All right. All right, YouTube, my friends. Be well. I'll see you next week. All right, my face.